Hello from Waynesboro. Nancy is saying hello. Oh, hi, you guys. I think we're just trying to get, yeah, we're getting live now. Okay, welcome in. Hello, everybody. We are now live for our night 3. I don't know about you guys, but this has been so much fun. Michelle, have you had fun?
I always have fun. Sorry, I had to unmute again. Yes.
Okay.
So much fun. This is so much fun seeing everybody's faces.
Yes, it is great. We love seeing your faces. So come on Zoom. If you're on Facebook with us, come on Zoom. That way you can come to the breakout session. That's where the magic is really going to happen tonight, you guys, in the breakout sessions. You're going to have half of you are going to go with Michelle, half of you are going to go with me, and we're going to do more practice like we did night 1. So how many of you guys liked the breakout sessions on night 1? I can actually see your chat. I don't have the thing up yet, so I can see it. So how did you guys like night 1 breakouts? Was that helpful for you? Hopefully. Do you see any chats? I don't see any chats
I
yet.
just see hellos so far.
Okay, I think, okay, there we go. Now they're coming through. Very helpful. Okay, good. So you'll enjoy tonight because we're gonna do, let me get my slides. We're gonna do, and you can see my slides, right, Michelle, hopefully?
Yes.
Okay,
Yes, we can see
yeah.
them.
All right, so we are now officially ready to rock and roll. So welcome in to night 3 of our 3-day EKG challenge, where tonight we're going to be doing 12 lead EKGs. And so we're super, super pumped that you guys are all here. It's hard to do 3 nights in a row, right? When we're all working and crazy. But it's also something to come home and look forward to. So it looks like we need a Zoom passcode in for Erin. Ruben, if you're able to give her the Zoom passcode. But yeah, we do want you guys all in Zoom with us. And so tonight we're going to do a 10-step approach to the 12 lead. So you have a systematic approach. And then in our breakout sessions, we're going to do some practice. And we really want you guys to interact with us. And we're going to do the rest of our workbook. So you should have, and I know you guys have all been here so far already, but just in case there's any new folks, you should have your 3-day EKG workbook. We are going to do the last 3 pages of it tonight. And when we're done, I will also post the answers in the group and I'll pin them to the top so that you guys can see the answers just in case you're rewatching. I know a lot of people are at work and working out in the hospital and crazy. So good. Ruben gave us the passcode if you guys need it. So let's get kicked off. What? All right, here we go. All right, so basic 12 lead. Also tonight, just a little housekeeping, is we are going to be giving away our scholarship tonight. So you guys who are live are going to be in it to win it. Now, this scholarship is very special. Obviously, this is my late dad. And, you know, when you want to give back to your community, it's always nice to have like a good reason to do it. And this is the best reason I can absolutely think of. This is my sweet dad. And in his honor, we're going to give away a scholarship to our 8-hour course, our 8-hour EKG course, which has arrhythmias and basic 12 lead, right? Taught by Michelle, who's an amazing coach, as you guys all know. And then you're going to get to go to this live portion with me on Saturday from 9 to 12 Pacific Standard. And you'll get a ticket to all of that, right? And you'll have lifetime access to the recorded part. So you really want to win this scholarship. Right? This is going to be a great scholarship. But of course, if you don't win, we're going to talk about how at the end you can join us in this class. But let's go on with our course of the evening. Let's go back and talk about what a normal EKG looks like. Now, if you guys remember from night 1, I talked about the road to getting good at EKGs. And I know from now working with you guys in the breakout rooms that I know that a lot of you are kind of struggling with what normal looks like. And so that's why I just kind of want to bring it out and talk about it so you have a frame of reference. So when you see something abnormal, then you know, oh, that's not what normal is. And so therefore I must investigate further. Okay. And I'll tell you that, let's see, I have a skewed perspective because I work in cardiology most of the time, right? So I had like 2 out of 16 EKGs today that were normal. So there is a lot of abnormal EKGs out there. And the other thing I just wanted to kind of plant in your mind is I know that in primary medicine, primary medicine. I know a lot of you are primary. I know that we always have this like false sense of security in primary where we're like, oh, yeah, the chest pain patients won't find us. I'm in primary. They're going to know to go to the ER. Well, we also know that that's not true. We wish that was true, but it's not true. They're going to come and find us because you're primary, right? And you love your patients and they love you back, right? And oh, David's here. Oh my gosh, David's here. David, are you by chance on Zoom too? Ruben or Michelle, is David on Zoom with us? And if not, if he is, let's get him on with us. But David is our, I talked to you about him the first night. He's our EKG guru and we love him. So he is a coach in our programs, but sometimes he blesses us and comes on our free courses too, which we always love. So so anyway, it's not a safe thing. It's not a safe harbor from these bad EKGs in primary. And honestly, urgent care either. So if you work in primary urgent, you're like, oh, it's going to be fine. The machine can just read my interpretations for me. As we know, the machine interpretation is right anywhere from 6 to 42% of the time. So if we can't rely on that, if any of you got to see Gary's lecture last night, what he said, which I really resonated with, was he said, you know what, you know who you can trust? You can trust yourself. And David teaches that too. And I know Michelle does too. We all have the same thought that the machine will lead us down bad roads if that's all we have to follow. So let's set you up to win by giving you a normal EKG rundown. So this is as close to normal as I could find. And mind you, this is what I did to find this. Okay, this is how hard this was. I told my EKG tech at the ER, I said, hey, can you look up like, you know, some 20 or 30-year-olds that you've done recently and find me a normal EKG? So she gave me like 10. And I was like, oh, this isn't normal because this. And this is, nope, this isn't normal. And all the machine reads were normal. So a lot of things are not read by the machine. And that's the scary part. So what David does, what he teaches, and what I do too, is we take the machine read and fold it over and do our own interpretation. And then we look back at the read to see if maybe there was anything that it said that we either agreed with or didn't agree with. So looking at this EKG, it does say normal, but let's talk about why this is true. So first things first, we're going to do this tonight in our 10 step, but we're going to go through these numbers here. Now, how many of you have been using these numbers when you read your EKGs? How many of you think that these numbers are beneficial? And put it in the chat because I know Michelle can see. And when you start, and you guys can see each other's chat too, I'm sure, but you'll start to see that there's a lot of people who don't use these. And the reality is that I was also taught when I was in paramedic school a long time ago, I was told, yeah, you don't need those numbers. Those are for the cardiologist. Well, that's actually not true. There's a lot of clues that lie in this number. And in fact, just to start off with one that's very important, for example, is the QTC. And we're going to talk about the QTC and why a prolonged QTC can be bad. Okay, we talked about that a little bit last night. If you were here to have the torsades, if you saw that in our breakout, or actually Gary's session. So going over these numbers is important. The other thing is we should have our family intact. So the P and the QRS and the T should all be standing next to each other, holding hands like a little family. And if they're not, then you start thinking about problems. If your T wave is really far from your QRS, that's most likely a prolonged QT. If you have a P wave, the mom of the family, standing really close to the dad, then you have to worry about things like Wolff Parkinson's White. So this is really helpful to see your family intact. The other thing you want to see, there isn't a lot of artifact. So my rule for artifact is that if I cannot see in any lead, if there is ST elevation, or for sure if there is a P, I will ask for it to be redone. I know that there is a lot of guilt when we do this surrounding that. I know that. We don't want to trouble our coworkers. They're already overworked. We don't want to seem like we're being difficult. But here's the reality. What's difficult is not being able to see a P wave because of artifact and sending home an AFib patient to go have a stroke because you didn't ask someone to redo the EKG. So at the end of the day, right, get the redo if you can't tell. Now, the other thing I wanted to point out, we talked about this on night one when we had the waves, was that all the T waves should be upright except for AVR and V1. And that's also what's happening here. This is normal. We like to see this. So you can see that you've got your T is good here. I put little check marks on the good ones. I'm like, yep, you're following the rules. So are you. So are you. You are too. And you, and you, and you, and you guys too. So everybody's passing the check mark test. And it's pretty rare, honestly, but we hope for that. Now, the final thing I want to show you on here, because this is the crux of like this entire 3-day challenge. By the way, the challenge was to be here 3 nights in a row. That's the challenge. We didn't want to make life more hard for you, right? People are like, oh, it's a challenge. I'm scared. No, it's just a challenge to be here 3 nights in a row. If you can get here 3 nights in a row, we're pretty excited for you. So, okay, this is the crux. You have to be able to adequately and accurately look for ST elevation and depression. And it has to be the right place on the EKG. Because if you know that one box of elevation or depression can make or break the STEMI diagnosis, and if your eyes are getting anything like mine, they're getting older by the day, right? I need glasses now to read these darn things sometimes. Okay, you know that you can't always trust your eyes. And even when I had great eyes, I couldn't always trust them because sometimes it's super, super, super minutia details that we're looking for. And one box of elevation is minutia. But here it is, the devil's in the details. And you have to get this right, or else you could send a STEMI home. So that's like a good motivator. So let me show you the trick. The trick is, hi, Baba. It looks like, and Baba and David are on. So anyway, going over here. Sorry, I'm getting sidetracked, squirrel. This is the segment right here. That's the money. This segment right here. This is called the TP segment. There is 2 times where we really ever talk about the TP segment. And honestly, probably a lot of you have never heard of this segment before. And that every challenge, when I can actually see the chat, I can see that, right? But here's why. Nobody probably ever showed you that this is where you look for the ST elevation and depression, right here. This is where you line up either your RCAT window badge if you have one, or you line up your paper and your pen. This is that segment. The other time we use this segment is when we potentially have a pericarditis patient, okay? Because a lot of times this segment will kind of stair step down with a pericarditis. So yeah, Libby says she has never heard. And I know, I don't know why they don't teach us this, but it's really important. So why is this segment important? This is your most isoelectric line, which basically means it's the flattest, it's the most true north that you can find. Now, what I did was I already made the line for you to show you what I want you to do. Now, if you're wondering, Jen, why did you only put it on one line? Well, I did that for speed, but every EKG, I go across the whole thing, every line, every lead, and I look, because you do not want to miss any ST elevation and send home subtle ischemia. And that's, I think there's a couple of things that keep us awake at night. I think that, so here's the thing, I got to redraw that one because sometimes when they're kind of a little bit askew, you have to go lead to lead. So here's my TP. Even that's not great. I'm using a mouse. Michelle always has the pencil. She's really good at this. So if you look here, that's my TP, right? There's no ST segment elevation. And my TP is right here. So that's where I line up with, okay? So you're looking every single time at that TP to see if there's enough elevation or depression to be significant. So I do it on every line. And then I look to see if there's any ST elevation. If there is, I see how much it is. And if there is, I see if there is, Tori said it's hard to draw the mouse. I know, right? And I look to see if there's elevation in contiguous leads, which we're going to talk about in our breakout sessions. And I look to see if there's reciprocal depression in reciprocal changes, right? In reciprocal leads. Now, we're not going to cover that really in this challenge. We'll cover that in our workshop this weekend. But I do want to at least cover this very important segment, and I do want to cover a 10-step approach with you. Now, if you guys want to get out your workbook, we're going to be doing, and I want you to follow along. And if you go to the page that looks like this, you can write along with me because we're going to go through all 10 steps, okay? I already filled out the answers, but yours will be empty unless you already did the homework ahead of time, which, oh my gosh, right? So those are things we need to know are normal and not normal. Okay, so getting on with the story. We're going to do our 10-step system now, and let's just dive into it. Now, I think I have a couple of versions of this, but this is what we're going to go through step by step, looking at one EKG, all the steps, so you guys get a chance to really see how this flows. Caveat, if you have already a 10-step system in place or anything that you use that you like, don't use ours. But I'll just give you a little secret. What I did when I was first learning is I just picked and chose things I liked from other people's systems. And honestly, David and Dr. Grauer, that are also, you'll see his posts a lot in our group, they have a different system too. It doesn't matter whose you use. We just want you to get the answers. We want you to make sure you don't miss anything. So this is mine, and you can take it and we'll show you how it works. Or you can pick out the things you like and replace the things that you don't like. But here's how this goes. Now, I got to tell you, I taught at a at a fire department Monday, right, during the day. And it was really great because it was all paramedics. And I said to them, I said, okay, big sick, little sick. Now, here's the thing I didn't understand for a long time, that if you're not in EMS at some point in your life, you don't understand what this means. So here I am saying this to, a bunch of medics, and they're all, oh yeah, big sick, little sick. But because it's so valuable, I want to share with you what that means. So when you go into a room and you look at a patient with chest pain and they are pale, cool, diaphoretic, they are leaning against the bed, they are quiet as a mouse because they're hiding from death, basically. And their heart rate is like 120 and their blood pressure is like 60 systolic, right? Is that a big sick or a little sick patient? Now that's easy, right? This is a big sick patient. You need to be able to identify the big sick patients in the EKG as well. So examples of that would be things like MI, asystole, ventricular tachycardia, VFib, super Brady, super tachy, any torsades, right? Anything that's like, you're not going to do a 10-step because you're getting them to the hospital. Now, if they're anything other than that and they're little sick, and little sick patients, for some reason, like UTI patients come to mind, right? They're kind of doing the pee-pee dance, or the like, oh, it hurts to pee, they look great, their skin signs are great, their vitals are great. That's a little sick patient in like the comparison to people EKGs, right? But in EKG world, if you had like, a flipped T wave, or they're a little tacky like a sinus tach, or they're a little Brady, like 50 heart rate 56 and it's sinus, like little sick things, we can do the rest of the approach. So step 2 is rate, step 3 is rhythm, 4 intervals, which is the numbers, step 5 axis is part of that. Step 6 is going into our ST segments and lining up with our TP and seeing if there's elevation or depression, looking at how much voltage there is. We talked about that on day 1 with the waves, right? If it's lots of voltage versus little voltage, we worry about different things. We go in for step 8 and we look at all of our T waves. Now, I have a little joke about this. Are the T waves behaving badly, right? Are they misbehaving? We should make, Michelle, we should make like a T wave gang, right? And all the T waves that are really bad that need to go to jail. And then you're going to look step 9 if there's any Q waves, and then step 10 is chief complaint based approach, where you're going to look at their EKG based on their complaint for certain things. So for example, if you had a shortness of breath patient, you would look for an S1 Q3 T3, right? Ooh, we could make a song, Tori. We could make a song about the bad boy T waves, right? We could make a song, or they could be bad girls too, right? Either way. Okay, so here we go. We're going to do this EKG. We're going to do all 10 steps together so that you can see how this flows. So first things first, are they big sick or little sick? What do you guys think? And come off mute if you want to, or Michelle, hopefully you can see the chat.
You've got a
Big
bunch
sick.
of big sick. Yes.
Big
Okay.
sick.
Good. Why do you say that? Why is it big sick? David's here. Is that David?
Yes, it's me.
David's in the house. Oh,
The
you
elevation.
don't know how lucky you are. Okay.
Yes, that's the elevation.
Okay, good. Now, there is this elevation. So you guys, I gotta just take a second here, right? And I gotta get David up here on the spotlight. And I want to ask you, David, if you want to share with these guys before I tell them my system, do you want to share any of your pearls? Because we hardly ever get to be blessed. But want to share some wisdom with them while you're here?
What would you like me to?
Can you tell them, coming from like the most experienced medic in the house, right? And someone who looks at 30 to something EKGs a day, like, did you ever feel unsure in the
Oh
beginning?
yes. Oh yes. I was very unsure. My training for 12 leads was very, very poor. I think in school we got 1 hour of training for 12 leads. They showed us STEMI criteria and sent us out the door. You're now experts. Good luck. How untrue that is. We did not get any training on the numbers. We weren't even told about the computer interpretation, any of that. Everything I've done, I've had to learn on my own.
Okay.
You mentioned earlier the computer interpretation. Ignore that at first, do your own interpretation, use your 10 steps, then go back and look at the computer interpretation to see if you missed anything. But I never start with it, never, ever.
Well, awesome. Okay, David, you'll love this. This break. You obviously love this EKG. I know you do. There's actually, I'm sure David will fill us in on this part in a little bit, but thank you, David. So guys, just to let you know, David is, he's our EKG guru of all of our courses. And it's because he's come from the very basic all the way to the very advanced, but he does it with practice. So whenever he gives us advice, it's so helpful. But this system, I'm going to go ahead and show you the rest of this EKG, and then maybe we'll have David, if he's still here, weigh in on any other details he wants to add. But this is a big sick, and you guys did notice some ST elevation. And so the question is, do you guys think this is a STEMI? What do you guys think?
I think it's a semi.
Okay. And hopefully we have a lot of agreement in the chat, but this is a STEMI. And so I'm going to give you a little hint. The one place where I look, if I do have in the software, it says acute STEMI, a STEMI accusation, as I call it, I will stop everything, not pass go or collect 200, and I will go straight to the ST segments. Okay. So that's what your eyes did. You went to the ST segments, you went straight to sub 6. And that's exactly perfect, because if you found a STEMI, that's it, you're done. Get them to the hospital, right? And if you're in the clinic, you're calling David to come get the patient. So STEMI accusation, you stop everything and you do your step 6. But if it's not that, then you can keep going. And you can look at rate, which is 71. So that's normal. Cool. All right. A lot of times the rate will be not correct, especially if you have somebody with big T waves, it'll get double counted. So always double check your rate. Easy way to do that is to feel the patient's pulse or listen apically. Now, the next question you have to ask yourself is, what's the rhythm? Now, I'm going to tell you that this one actually, sorry, going over here, the rhythm is, they pulled out V1 for you down here. And down here, actually, you can't see it on here. I think I have to go to here. Hold on. But the rhythm you can see is definitely sinus, right? You have a P wave. It's beautiful and perfect. And one of the best places to look is in lead 2. And you know that the PR interval is this normal distance away from the QRS. So that's also good. And it's a normal rate. So we do have a sinus rhythm. Now, the next thing you're going to do is you're going to go through these numbers here, which are the intervals. So does anybody see Any numbers that stick out at them? Does anybody see any numbers that stick out?
You've got QTC, QT prolonged.
Mm-hmm. Okay. Now David's going to say, there's a saying that David has, and he says, I believe that machine software as much as I trust gas station sushi. I probably just slaughtered it, but there is the machine saying there's prolonged QT, and there is a 713, and this should be under 460. Okay, Melissa Mainville caught it. But whenever you have this accusation, you got to go in and double check it. Here's how to do it. I'm going to show you the secret. What you do is you come over and you find a place where you think through all this artifact, you can see a T. So you scan, 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 scan. So I think I see a T right here. So I make a line right here where I think I see a T, and I go all the way up and all the way down. And I think I look over here, I think I see a T, and I definitely see a T over here. So, oh, that's bad drawing, hold on. So when you do that, if your T wave is not yet halfway between your R and R, then that's not correct, because if you have a T wave that's over 500, it's going to be between your R and R. So it's unfortunately a bunch of sushi, as David would say. So when you redo the EKG, when you don't have artifact, you will get accurate numbers. And there you can see that, yes, without artifact, there's the T wave, and it is indeed 444. So that's why rule number one, it's really important not to have any artifact. Okay, so you can imagine if you saw a 713 QT, you might send that patient to the emergency room and they would redo your EKG and they would be like, it was fine. So always make sure you just do that extra layer of protection for yourself. Now, I think I put ST segments as number 5 on this, but again, you're going to take out your pen and you're going to go through and you're going to grab your pen. Okay, and you're going to go through and you're going to look at all your ST segments. And so far, we definitely have ST elevation in 2, 3, and AVF. Now, the intergalactic definition of STEMI, as David always likes to tell us, is we need to have 2 leads with elevation and 2 leads with depression that are contiguous and that are reciprocal. So do we meet that criteria with what I'm showing you here? What do you guys think? Do we meet that criteria?
Erin says yes. Melissa
right.
said yes.
Let's see what David has to say, our STEMI expert.
So, yeah, this is very concerning. This patient definitely needs to go to the cath lab directly. Lots of stuff going on here. So we've got ST elevation in all 3 of our inferior leads, 2, 3, and AVF. We have, more importantly, we have reciprocal changes in 1 and AVL. We have ST elevation with a straight ST segment in 3 that is more than in lead 2. So that's why the computer says consider a right ventricular infarct. In addition to that, the ST segments in V1, V2, and V3 have been drugged down. That's going to indicate a posterior involvement. And then we also have elevation in V4, V5, V6, which also agrees with the left circumflex wrapping around the posterior being involved. So we could have either one, a right ventricular infarct with posterior involvement, or 2 multi-vessel disease here.
So thank you, David. That is where we all want to be like David one day. And this is a basic course, and this is where you can get to if you hang around with our crew. You can be like David. So this was a STEMI, so good job. And like David pointed out, the lead 3 over lead 2, right? Concerning for right ventricular involvement. And that would affect EMS, especially David, right? Because you would change your management of this patient potentially.
Yeah, so especially, so, you know, we talked about this the other day in one of the study halls, inferior infarct versus a right ventricular infarct. With inferiors, a lot of the literature, a lot of the doctors you talk to, they're kind of split 50-50 on nitro. However, when we're talking about specifically a right ventricular infarct, these patients are heavily dependent on their preload, and the preload's being affected. So we absolutely want to not give nitro or any kind of nitrates to a right ventricular infarct, and we want to actually support the preload. In EMS, we want to do that with fluids.
Cool, cool. Yeah. So see, you're hearing it straight from EMS, who has to make critical decisions like that. And you do too if you work in the ER and then potentially inpatient. Now, step number 6 is looking to see if there's Q waves and looking to see if the P and the QRS are married. Are they coming at the same expected time? Are they holding hands? Right? You should never see Q waves that are at least a third the height of the R wave, and never in V1 and V2, as Dave always likes to say. And then you also would scan the axis real quick. And I'm just going to tell you, for our purposes today, we really only care about axis when we're dealing with either a wide complex tachycardia or if you have potentially like a pulmonary embolus. But other than that, and when you deal with things like hemiblocks, but for our basic purposes, we're just looking to see if this number is between 0 and 90, okay? And then number 8 is we're looking to see how big our R waves are, because remember, if they're too small, we worry about pericardial effusion as a bad thing, but it can also be caused by obesity and large body habitus. And then we're looking to make sure it's not too big, because too big can potentially mean left ventricular hypertrophy. And David talks about that a lot in our other classes. We want to get him started on that because he's like the master. Now, the T wave rules, right? We're looking to make sure our T waves are all upright, except for the ones in AVR and V1. And this one is upright in V1. Now, sometimes, as David likes to tell us, that can be a normal variant, but other times, right, especially in the setting of an ischemic EKG, that should make us concerned. So we always want our T waves to be upright, except for AVR and V1. Now, the final component of this is doing a chief complaint-based approach. So if you have someone with chest pain, you're going to look for STEMI, you're going to look for PE, pericarditis, you're going to look for all the things, right? And if they have syncope, you're going to look for heart rate issues, you're going to look at the QT, right? So it always matters at the very end to go back in and look at their chief complaint. Now, I have a practice case for you guys, and we're going to do it, and David's going to be here, and you'll be surprised. Okay. So we have a walk-in patient. This is him, and no, this is not anybody's real face, but he's complaining of chest pain, and he's coming to your primary care office because he says he knows you and you'll take care of him. And the COVID's at the ER, so he doesn't want to go to the ER. So here he is, room 1, we'll call him Wayne. We'll pretend this is a real clinic. It's a clinic I made on PowerPoint, but it looks pretty legit, right? Except for the no charts thing, right? And so let's see what's happening. So Wayne is 47 and his blood pressure is low on the low side. He's a dialysis patient and his heart rate's 120, respiratory rate is 24. His temp's 100, so he's looking a little SIRS-ish, right? And he's not looking too hot on his exam. So we call David. David's en route, and meanwhile, we are going to do an EKG. While we're waiting for the EKG, we do a quick exam, and you notice he has a continuous rub when you listen to his heart, and then you're like, ooh, that's not good. You look at his legs, and he's got some venous stasis changes, but that's no surprise. He's chronically ill. He's got some JVD. You're not liking that. And his lung sounds are diminished, so you're also concerned about potential heart failure. Well, we do an EKG, and drum roll, please. Here it is. Now, imagine that you have to make this decision by yourself, which I know a lot of you are solo providers. And Daisy, who's here with us on Facebook, she said, miss dialysis? Absolutely, Daisy. And I know where she's going with that. She's wondering, and she's potentially looking for the big T waves, right, with hyper K. But yeah, so I know where you're going with that, Daisy. That is the absolute right thing to think. But this patient, we don't care right now about his K because we have a STEMI accusation. So we got to go. We got to look at his ST segments, right? We're going to stop everything and do the ST segments. So we're going to line up with our TP, and we're going to see if there's any ST elevation And what say you? What say you? Is this a STEMI? I mean, do we meet the intergalactic criteria? And we've got all this ST elevation. This is like a bunch of junk over here, so we can't even really see what's happening. But what do you guys think? Is this a STEMI? What are we getting in the chat, Michelle? Any messages?
You have tamponade, drive faster. Nicole says drive fast. Pericarditis, inferior, no depression, widespread ST elevation, and a rub pericarditis. Looks like all leads lead to pericarditis.
Ah, okay. So this was a tricky one. We did this on purpose, but I want you to picture something, and good job to everybody who picked that up. This is not a STEMI. This does not meet the intergalactic definition. There is widespread ST elevation with no reciprocal changes. And I just want you to picture for a second that you have two eyes and a nose. And these ST segments are smiling because they're not a STEMI. Okay, so this was a pericarditis patient. The rub was a clue, the widespread elevation. And there's also a couple other findings that, David, do you want to talk about the other little clues on this EKG?
Hey, yeah, so so there's a lot of different findings here. The widespread elevation is usually concerning, and that's what the computer's picking up. So this is absolutely not a STEMI. So during and I want to kind of tie this back into step number 8, hypertrophy and voltage. So when we have an ischemic event, even if we have a patient with known ventricular hypertrophy, okay, even if we know that's their history, left ventricular hypertrophy brings very large voltage. During the ischemic process, we lose voltage, okay, even if they have a baseline LVH. Here, we have not only large voltage, we have very large voltage, especially in the inferior leads and the left lateral leads, V4, V5, V6. This is not STEMI. You will lose voltage during the acute occlusion process, okay? In addition to that, so that right there, the very large voltage extremely favors not STEMI. Number 2, there's widespread J-point notching. There is widespread ST elevation. During the acute occlusion process, we typically localize to a specific contiguous set of leads unless there is multivessel disease or left main stenosis. What we also see here is the kind of stair-step process we're seeing that's really prominent in lead 3 and AVF. If you'll notice, we have the TP segment, then we have the ST segment, and then we have that down-sloping ST segment, or the TP segment again. So it's kind of like a stair-step going down. That's a sign favoring pericarditis. We don't have ST depression anywhere other than AVR. That is another favor for pericarditis. We also have a little bit of what's called the knuckle sign. So if you look in AVR, we have an inverted P wave, which is normal. And then right between the P wave and the QRS, the PR segment, it looks like it's kind of poked up a little bit. That's called the knuckle sign. So when we kind of put all this together with a normal QTC, big voltage, widespread ST elevation, probably a little bit of PR depression, knuckle sign and AVR, no reciprocal changes, this heavily favors not the acute occlusion process. Is that enough?
Yeah, I think so. So yeah, that was like a really good deep dive. That's the kind of stuff that we do in our more advanced classes, just so you guys know. But it's nice for you to see that, because this is like, David is what you can be with practice. And that's why I love when he comes on and shows us like his magic. So that was a pericarditis. And here's you making your straight lines, knowing that this is indeed not a STEMI. So again, the machine's not always right? This is a sushi, as David would say. So do you want to do one more case? What do you guys think? Are you bored, or do you want to do one more? What do we think, Michelle? Do they want to stop, or do they want to do one more?
We hear one more. We've got lots of jumps for one more.
Okay, then we'll do one more. All right, so we're gonna do Phil. So Phil, this is not anybody's real face. Same clinic. This clinic is having a bad day. So Phil comes in, and Phil's got some chest pain that he's had for 3 days. Now, today Phil has eaten 5 nitro, and his pain is still there. So what do you want to tell Phil if he's in your primary or urgent before you even see his EKG? What are you going to tell him? Chest pain with eaten 5 nitro. Laura, it looks like you're off mute. Do you want to have a comment?
Lie down because it's pressure.
Lie down. Yeah, that's a good idea. Lie down, Phil.
Yeah.
We're going to lay him down to get an EKG, so we'll be laying him down. But if you ate 5 nitro and your pain is still there.
We've got a bunch of people saying that if you've taken more than 2, you need to be calling 911. Avoid Viagra.
Yeah, when you start taking the third one, we say call 911.
Okay, good. I agree. So something is going on with Phil that's not good. So we did lie him down, Laura. I'm sure you'll be happy. And we got an EKG. So now what do we do? It says this non-specific ST elevation, or sorry, ST wave abnormality. And you know, we gotta figure out what to do. Is it a STEMI? So we're gonna, you know, we know he has chest pain, so we're gonna go through and do, you know, our ST segments, right? We're gonna, oh wow, that's really bad. Hold on, let me redo that. Why did I get all these back? Huh. That's weird. Okay. So we're doing our ST segments. It's not really meeting criteria for STEMI. Should we still send him to the hospital? What do you guys think? Do you think you want to send Phil to the hospital?
You've got a lot of yeses, flip T's in the lateral leads.
Mm-hmm. So the T waves are upside down.
Bria wants to go to the emergency room.
Good call, Bria. Good call. And Daisy said tall T waves. Agreed, Daisy. And so, yeah, this guy did go to the hospital, thankfully, and he ended up being a code STEMI 5 minutes after this EKG. Okay, so you guys did great on picking up the inverted T waves here, and Daisy did a great job on picking up the big T waves here. So big T waves a lot of times are something that occurs pre-STEMI, okay? So there's a lot of things that I'm just gonna tell you guys, I don't wanna scare you, but when you see this ST T wave abnormality business, there's at least 5 things that can be on your EKG that are bad, that are sent to the ER and don't refer to cardiology, but none of them get printed out in the printout. So if you're a provider that just relies on the printout, you're going to be potentially missing these things, and your patients are going to have bad outcomes. So we'll be talking about those 5 things this weekend in the class. But in the meantime, what I want to do is wrap up really quick. I want to talk to you about the scholarship, and then we're going to go into our breakout sessions. If you guys want to stay and do practice, me and Michelle, we're going to do our workbook and some cases. So just to wrap up our whole challenge, okay, for the 3 days, we know that we don't trust the EKG interpretation. We know that the family should all be holding hands. We know to look at those intervals because there's clues that lie in those. And we know the sinus node should always run the heart. And what's the saying? The sinus node makes, what's the saying? Sinus node makes
P. Marion, Ashley, everybody says makes P.
Good. All right. Awesome. Even Tori, who doesn't even know. Tori. Love it. Okay, good. Now it's time to do our giveaway. So this is Remy and me getting ready to give the giveaway. What we're going to do is I'm going to give this away on a separate drawing. I'm going to come back on just to tell you who got the scholarship afterwards, because I don't have any downtime to write your names down. But the hashtag to be put in for the scholarship winning is #dad. Easy, #dad. Okay. And so put the hashtag in either Zoom or Facebook. We'll be coming on and doing the drawing after. But in the meantime, just to tell you guys what you are potentially entering. If you want to enter, you don't have to, right? But we're going to tell you what you're entered to win. So you're going to get access to the basic EKG program that Michelle and I have already recorded. So we did basic arrhythmias. Michelle does her whole basic foundations for 3 hours. And then I do a 3-hour workshop as well that is already recorded, and you'll get instant access if you win to that whole learning portal, and you'll get lifetime access to it. Okay, so it's like the foundations, plus you'll get access to the 3-hour workshop that I'm doing on Saturday from 9 to noon. That will be recorded as well and uploaded into the portal. So don't worry, you won't be missing that if you can't make it live. But if you make it live, we're going to color code the EKG together with colors so we know contiguous leads. We're going to make a cheat sheet for you. We're going to do a drawing of coronary anatomy and match it up to the actual EKG. And then we're going to go over 17 real EKGs, and you're going to get that sent to you as a workbook. And we're going to talk about the 5 things that when the machine says non-specific that you need to miss so you don't send your patient home to die. Okay, now if you don't get our scholarship, right, you can still get in with us. I'm just going to tell you what you'll get, and then we're going to go into breakouts. So we're going to do the scholarship winner drawing tonight. But if you don't win and you want to join us, it's totally worth it, because what we have is we have the workbook you're going to get sent to you. You're going to get 8 hours of CE if you're a PA, NP, RN, or EMS. You get the basic workshop with Michelle. You get hands-on practice with me this weekend. You get a cheat sheet that we send to you, and we make one with you. And then you also get the live session and the recorded sessions, right? So all of this for just $75, which normally, if you go on our website right now, it's $127, but we're giving our 3-day members, we're giving you this discount. So let's, this is one of the EKGs we're going to make into a cheat sheet. And I'm going to tell you, this is reading normal ECG, but it's not. There's a couple of problems on here. I'll tell you what they are when we do the workshop. And in the meantime, this is not actually a normal EKG. So let's go to our breakout sessions and bring your workbooks with you. We're going to do 3 pages of this tonight. Okay, so bring these with you. And Ruben, if you can bump us all into the breakout sessions. And in the meantime, while we're getting ready to do breakouts, I see all of you put #dad. Okay, Robert, see you later. You got to go. I understand. But let's get ready to go into our breakouts.